My chosen complexity for this presentation is a Māori woman's experience of miscarriage in Aotearoa, New Zealand. The first portion of my presentation will focus on introducing my chosen complexity and discussing the different factors present according to scholarly literature for Māori wahine who are experiencing a miscarriage in New Zealand. I will take this opportunity to explore the topic not only through a biomedical lens but also a spiritual and cultural one, helping me to understand this complexity within the context of Te Ao Māori, the Māori world. I will then discuss how I, as a future nurse, would work with a woman experiencing this complexity through the practical implementation of best practice policies, legislation, protocols, and New Zealand Nurses Organisation guidelines. A miscarriage is the spontaneous end of a pregnancy before the unborn child reaches viability, which is between the time of conception and 20 weeks gestation. Globally, the percentage of women who have experienced a miscarriage is surprisingly high, with approximately 15 to 25% of all clinically recognized pregnancies ending in spontaneous loss. This number jumps to an estimated 50% when non-clinically recognized pregnancies are also included. In Aotearoa, New Zealand, approximately 1 in 4 wahine will experience a miscarriage in their lifetime. There are several medically accepted etiologies for miscarriage, such as parental chromosomal abnormalities, untreated hypothyroidism, uncontrolled diabetes mellitus, certain uterine anatomic abnormalities, antiphospholipid antibody syndrome, and obesity. However, even after assessing for these etiologies, still approximately half, 50% of all miscarriages never have a medically diagnosed cause. The emotional and psychological impacts on both mother and extended family following a miscarriage is significant. Numerous studies have investigated emotional morbidity in women over the period immediately following their miscarriage. These studies found that 45% of the women in the study displayed high levels of psychological distress and major depression, along with levels of grief equal to people who have suffered the death of a close relative. Further studies also found feelings of personal responsibility and self-blame also contributed significantly to the elevation of anxiety and depression following the event. Literature on miscarriage within the Māori population remains minimal. However, several notable historical research projects were conducted in the late 20th, early 21st century on the lives of Māori wahine. Although their research did not focus on miscarriage, remarks from the women about pregnancy, infertility, and miscarriage were discussed. These projects can provide present-day health professionals with valuable insight into the classical culture and spirituality of maternity within Te Ao Māori. In 1986, a research project was conducted by Binney and Chaplin on the documented life stories of 8 Māori women across New Zealand between 1820 and 1921. Throughout the research, all 8 women discussed pregnancy as tapu, which, when brought to completion, connected the spiritual realm of divine forces with the human realm during birth. Also noted was the significant value placed on iwi continuation during pregnancy and the mana bestowed on women who bore and nurtured the next generation of whakapapa. As a result, women who miscarried or were unable to get pregnant experienced a deep level of shame and despair. Binney and Chaplin observed, the experience of childlessness, whanirano, is the thing most feared by Māori women. In a more recent project, Palmer surveyed Māori women's views of hapu and te wharenaro. The survey results showed that aspects such as wairua, whānau, and whanaungatanga were deemed by the women to be of greatest importance to their overall well-being during pregnancy and pregnancy loss. The study also discussed the classical worldview and lifestyle of Māori, including how comprehensive whānau structures, spirituality, cosmogony, folklore, and generational oral narrative continue to shape the maternity care needs of modern Māori wahine in Aotearoa, New Zealand today. As shown in these 2 research projects, pregnancy and maternity within Te Ao Māori has long been seen as a sacred task gifted to women. Graham and Masters Awatiri notes that this classical understanding of Māori culture and spirituality is necessary when wanting to provide health care to modern Māori under tikanga in Te Tiriti o Waitangi. This is because many of the classical protocols, beliefs, and customs have been passed down and so continue to influence the Māori approach to health, be it subtly or overtly. This is particularly true concerning sacred practices such as pregnancy and miscarriage for Māori wahine. Along with the spiritual cultural dimensions of maternity and miscarriage, socio-economic and geographical factors also have a large influence on the experience of miscarriage among Māori women in Aotearoa, New Zealand. Some of these socio-economic and geographical factors are demonstrated through the New Zealand Deprivation Index. The NZDI enables area-level assessments of socio-economic deprivation across Aotearoa, New Zealand, then ranks the level of deprivation according to deciles 1 to 10. In 2013, approximately 54% of the female Māori population lived in NZDI deciles 8 to 10. This was mostly within the rural regions of Northland and the East Coast. Further, these rural Māori-dense regions are known to have the lowest doctor-to-person ratios in the country. This results in a lack of access to healthcare services, information, and medical support for all Māori in these areas, including Māori wahine who are experiencing a miscarriage. Although little research has been done on this topic, the socio-economic and geographical population spread among Māori women has the potential to have detrimental effects on their health and well-being pre- and post-miscarriage. This trend of poor health outcomes for Māori has been present since the colonisation and introduction of European culture in Aotearoa. Studies from 1921 discuss the increased rates of miscarriage and infant death among Māori as being directly related to poverty, in particular respiratory diseases among women and children, which are attributable on scale to the poor housing conditions in which many families were and are living. Around the turn of the century, the New Zealand healthcare sector saw several advancements made in prioritising Māori-led healthcare and the introduction of Māori-led healthcare providers, including within the maternity sector. Through these advancements, models and strategies such as Te Whare Tapawha, Te Whiki, Te Paemahutonga, Tauranga Kaupapa, and He Korowai Oranga have been implemented as strategies designed to better care to the health care needs of Māori and so improve their experience of healthcare in New Zealand, including for Māori women experiencing miscarriage. Of these models, I will be discussing Te Whare Tapawha more in depth due to its holistic approach to healthcare. Te Whare Tapawha is a healthcare model which uses the structure of a Māori whare to illustrate the four dimensions of Māori well-being: taha wairoa, taha whānau, tāna tinana, and taha hinengaro, which are viewed as interrelated and working in harmony to influence an individual's overall hauora. Within the Te Ao Māori world, the belief that spiritual, mental, relational, and physical health work in partnership when wanting to restore or maintain hauora has been present for a long time. Before European settlement in Aotearoa, traditional Māori healers called tauhanga were experts in specific discipline and often had spiritual abilities, knowledge of the healing properties of plants, and an inherent belief in the interrelated nature of spirit, mind, and body. Applying this to my complexity of miscarriage among Māori women, attention has been drawn to the tension between Māori conceptualizations of childbearing as an embodied narrative of whakapapa and the Western European perspectives, which focuses primarily on the physical dimensions. This tension has historically led to misunderstandings and inequities within Māori healthcare, contributing toward poorer health outcomes for Māori in comparison with New Zealand Pākehā. However, healthcare models such as Te Whare Tapawha strive to bridge that gap between Western and traditional healthcare through more actively engaging with the other dimensions of health that are of value to Māori. The way nurses can approach the care of Māori wahine experiencing a miscarriage must begin with Te Tiriti o Waitangi. Nurses in Aotearoa, New Zealand have a responsibility to honour the rights and healthcare needs of Māori in accordance with the principles of Te Tiriti. This responsibility includes providing nursing care in a partnership that is characterised by mutual trust and cultural spiritual awareness for both wahine and their whānau. In the context of miscarriage, this partnership must acknowledge and protect Māori customs and traditions surrounding pregnancy and loss and providing Māori women with their definition of quality care. Legislations, guidelines and strategies such as Nursing Council of New Zealand's Te Tiriti o Waitangi policy statement, Te Whare Tapawha and Tauranga Kaupapa all function to improve health outcomes for all Māori across Aotearoa, New Zealand through implementing a self-governed, whānau-focused initiative rooted in Te Tiriti o Waitangi. They also serve as a solid framework through which nurses in Aotearoa can practically implement the principles of Te Tiriti within our practice. An example of this is the principles of Tauranga Kaupapa. whakapapa karakia, whanaunatanga, te reo Māori, mana, hauora, tikanga whenua, and te whare tangata, mokopuna and manakitanga. For Māori women experiencing a miscarriage who desire to receive care oriented specifically towards Te Ao Māori, this care is accessible through their local district health board. Examples of this include Māori Health Services, who work in collaboration with both hospitals and specialists, as well as primary and community nursing providers. There are also a variety of Māori Health Liaison Services, Māori Mental Health Services, Māori Health units, and Te Whare Whānau family rooms available within all DHB hospitals for hui purposes if desired by the woman and her whānau following a miscarriage. Within all these frameworks, nursing assessment, follow-up care and management are prioritised for women experiencing or post-miscarriage. When addressing the personal needs of mother and family following a miscarriage, comprehensive information, explanations regarding miscarriage, anticipatory guidance and counselling following miscarriage are best practices when offered as per the Tiratia Waitangi policy statement, as well as encouragement of compassionate social support to facilitate women's psychological and emotional well-being. As a future nurse, if desired by the women, I would utilise the Māori care resources available through the DHB through liaising with Māori care specialists to ensure that the needs of my patient were being met and that through healthcare collaboration, she was receiving her definition of quality care. Although minimal research has been conducted to explore Māori women's experience of miscarriage in Aotearoa, New Zealand, research findings can suggest that without adequate access to culturally respectful and competent care, Māori women's health outcomes will remain marginalised. Attention is therefore drawn to the importance of determining women's cultural perspectives and behaviours when designing care measures, as well as an increasing need for research specifically examining Māori women's experiences of miscarriage-related care in primary and institutional healthcare settings. In conclusion, although the literature on miscarriage within the Māori population remains minimal, several factors have been identified to contribute to the way Māori women experience miscarriage in Aotearoa, New Zealand. The two main areas of influence I have discussed are around wairoa and socio-economic/geographical complexities, both of which, when understood by the nurse, can allow for more patient-centred, individualised and comprehensive care. The way nurses can approach the care of Māori wahine experiencing a miscarriage must begin with Te Tiriti o Waitangi. This can be demonstrated through working within best practice guidelines and following healthcare strategies and initiatives such as Te Tiriti o Waitangi policy statement, Tauranga Kaupapa and Te Whare Tapawha. These both function to improve health outcomes for all Māori, including the care of Māori wahine experiencing a miscarriage across Aotearoa, New Zealand through implementing a self-governed whānau-focused initiative rooted in Te Tiriti o Waitangi. As well as this, it is best practice for nurses to utilise the Māori care resources available through the DHB by liaising with Māori care specialists and ensuring that the unique needs of each woman are being met.